A newly admitted patient comes onto the ward, and their lab report shows a suddenly low potassium level of 2.8 milliequivalents per liter. If we misidentify the cause of this deficit, or if we replace the electrolyte incorrectly, we risk triggering a fatal cardiac arrhythmia. To manage this safely, we will use the exact clinical protocols established in the 37th edition of the Washington Manual of Medical Therapeutics. We will build a two-step diagnostic algorithm to identify the root cause, followed by a strict safety protocol for both IV and oral repletion. Effectively managing hypokalemia requires identifying the underlying mechanism, rather than simply reacting to a number on a lab report. At 2.8 milliequivalents per liter, our patient falls into the severe hypokalemia category, defined as anything below 3.0. At this level, you must actively examine the patient for physical symptoms like severe muscle weakness. Your immediate next step is to obtain a 12-lead ECG to check for life-threatening cardiac effects. This diagram compares a normal ECG tracing with a hypokalemic one. First, look for the visual flattening or inversion of the T waves. As the condition progresses, a prominent U wave appears right after the T wave, alongside ST segment depression. Once the heart is secure, we look at the patient's history. Before ordering extensive diagnostic labs, you must rule out a transcellular shift. Insulin or alkalemia can cause potassium to temporarily migrate into the intracellular space. Blood levels drop, but total body stores remain the same. Determining if you are facing true potassium depletion or a temporary cellular shift is the necessary starting point for your treatment plan. Once we confirm true depletion, we start the first step of our diagnostic algorithm, assessing how the kidneys are responding to the low potassium state. We gather this data by ordering either a spot or a 24-hour urine potassium test. This algorithm breaks down the possibilities. On the left, a urine potassium below 15 defines appropriate conservation, pointing directly to extrarenal causes, like GI losses. On the right, renal wasting, a level above 15, indicates the kidneys are actively dumping potassium. This single urine test instantly cuts your differential diagnosis in half, saving time in an emergency. For patients in the renal wasting category, we take the next diagnostic step to pinpoint the underlying disease, evaluating their acid-base status. Looking at the expanded right side, we check for metabolic acidosis, which links to conditions like distal renal tubular acidosis, or DKA. Alternatively, metabolic alkalosis links to a different set of triggers, like diuretic use, vomiting, or hyperaldosteronism. Overlaying acid-base status onto the urine potassium data provides a precise diagnostic path to the root cause of the deficiency. With the diagnosis secure, we enter the treatment phase. But first, you must address a factor that frequently causes repletion to fail: magnesium. Concurrent hypomagnesemia makes the body refractory to potassium replacement. Because certain cellular channels require magnesium to function, you must correct that deficit first. For mild patients, we use oral repletion. Standard formulas often underestimate the true body deficit because potassium continually shifts back into the cells during treatment. This cheat sheet outlines oral dosing. Peripheral IVs max at 40 milliequivalents per liter, central lines 100. The maximum infusion rate is 20 hourly. Strictly adhering to these speed and concentration limits is the only way to safely reverse the deficit without triggering a fatal cardiac event. Returning to our initial patient scenario, their ECG has successfully normalized following treatment. The algorithm correctly identified their recent diuretic use as the culprit. By following the repletion rules, we safely corrected both the potassium drop and the magnesium deficit. These are the completed tools: the hypokalemia algorithm and the repletion cheat sheet. Capture these clinical tools for your next shift and subscribe for more ward-ready medical tutorials.